Welcome to Leadership in Business, an official podcast of the AUA. This episode is brought to you by AUA Public Policy and Advocacy and was originally presented as a virtual event on September 19, 2023.
Good evening, everyone. It's my honor to welcome you to Capital Conversations organized tonight by the AUA. My name is Dr. Ruchika Talwar. I was the 2022-2023 Holt Grew Legislative Fellow, where I had the pleasure of working in the House of Representatives and having a robust session with Dr. Dunn on prescription drug pricing and access to healthcare services. He's joining us tonight to discuss physician payments. Dr. Neal Dunn has represented the 2nd Congressional District of Florida since 2017, which includes all or part of 16 counties in North Florida. He was a surgeon in Panama City for over 25 years and in the U.S. Army for over 10 years before that. Congressman Dunn currently serves on the House Energy and Commerce Committee, the Parliament of NATO, the House Select Committee on the CCP. He and his wife, Leah Dunn, are proud to have raised their 3 sons in Bay County and continue to share the same traditions with their 3 grandsons. As I mentioned earlier, tonight, we'll be discussing Medicare physician payment reform and your perspective, Dr. Dunn, from the halls of Congress and as a physician on the future of reform. Just a few housekeeping items before we dive in. For the audience, please place your questions in the Q&A box and we'll make every effort to get to them at the end of the webinar, time permitting. Dr. Dunn, let's get started. Let's basically kick it off. Oh, go ahead, please.
No, go ahead.
I was going to say, let's kick it off with a bit of the history of how we got to this state of physician payments.
All right. So I've been in these trenches of CMS payment reform for longer, I suspect, than most of you have been practicing. This started the day I got out of the Army, because I was on the salary there, right? I mean, I knew nothing about running a practice, but I was hired by older fellow in practice, and then I had to start learning because he didn't know what was going on. So, I found right away that, CMS only does one thing: they lower your reimbursement rates, period, and they obstruct new care options, whether it's pharmaceuticals, devices, surgical procedures, everything. They're always standing athwart progress, and that started for me with lithotripsy. Because lithotripsy had just been invented when I was a senior resident at Walter Reed. And we were all doing percutaneous. In fact, I was teaching percutaneous nephrolithotripsy for the AUA around the country. Thought, this is great stuff. I'm going to be such a hot commodity when I get out of the Army because I could do PCNL. And of course, lithotripsy was invented like shortly thereafter. And you don't get all your guesses right, but then we watched the reimbursement level just down on everything, and it's never gone up ever in my 35 years of practice as a civilian. So there's a trend there.
Absolutely. And I think you've alluded to some of the major challenges with the Medicare physician fee schedule. But what are some thoughts that you and your fellow physicians in Congress have about any proposed long-term sustainable solutions?
So we actually, let me say, you have a very, very sympathetic caucus in Congress. It's called the DOC caucus. There's roughly 18 MD-DOs, a couple of pharmacists and podiatrists and stuff. So I mean, we all people who are well familiar with the medical community, and you have, even on both sides of the aisle, you have complete sympathy from everybody. I mean, they all want to see that go up, but you need 218 votes to make that happen. And we're short 200 votes. So it's just a simple pay for thing. And doctors don't generate by nature a lot of sympathy for reimbursement levels. There's still this very, very strong feeling that doctors are well paid. Don't worry about them. If we give them a 5% or 10% haircut, that's not that much. They don't realize the 10% off that reimbursement price is like 40% of what you take home.
Mm-hmm.
That doesn't, they don't do that math. But I had to do that math as a guy who ran a practice. And we found our ways, to work around that with ancillary care services and frankly forming large groups so we could negotiate better private care contracts. But that is grinding to a halt. Okay, so all that, we were able to bend the curve, but we weren't able to improve the situation. And now it's gotten to the point where even the hospitals who would have loved to have bought your practice a few years ago, now they don't want to buy your practice, because they don't pay for it. They just want you to work for them. And by the way, for less money. So that's the situation because CMS has undervalued your services. And CMS, like it or not, is the, sort of benchmark for what people are going to pay you. So when you negotiate with Blue Cross Blue Shield, United, Aetna, any of these, it's going to be Blue Cross, it's going to be CMS plus or minus, right? Because we were such a large group, we were able to negotiate CMS plus, but an awful lot of people are settling for CMS minus. And when you get into that territory, it's a hard way to make a living. So people start bailing on the practice. They quit, or they go to work for the hospitals. And the hospitals do not turn out to be great, sympathetic employers of doctors for the most part. There are a few systems, we can all agree, a few systems that work better with doctors than others, but most of them really don't want your opinion. They just want you on the clock. And that's where we are. I mean, even when they get a 20% boost over whatever you get from CMS, they are getting to the point where they're saying, "Ouch, we can't afford these doctors. We don't want to buy them." And we'll find some way to stopgap. And they also then start, let's be honest with each other. The quality becomes less of a metric when the reimbursement is so low. It's just like any warm body will do. And now you and I know there's some great surgeons, great urologists, great out there, and very, very bright. They're inventing new things, doing great things. But it's the money is coming out of the systems of the physicians. Having said that, the cost of medicine isn't going down. Where's the money going to? It's going to administration. It's going to pharmaceuticals. It's going to insurance companies, and then it's going to insurance companies, and then it's going to insurance companies. So when I was in practice, I thought the hospitals were the bad guys, and I ended up as chief of staff of a couple of hospitals, on the board of a couple of hospitals. I ended up on the board of Blue Cross Blue Shield, and I worked for some pharmaceutical companies who did a lot of clinical research. Let me tell you, if you're just looking for somebody to blame for all this, it's the insurance companies. All right. So they have come after, they are the number one people who undervalue your services. And CMS is sort of following along. Had a great conversation with Fred Levin, the director, very famous, powerful director of CMS. It was probably 12 years ago. And I said, how the hell can you keep doing this? You lower everybody's reimbursement every year. You can't, Matt, you can't think we're going to keep coming. And he says, I'm going to keep lowering your reimbursement until you stop taking my contracts. That's when I stop. Because right now I put a contract out and every urologist in the country will sign. What the hell do I care? I've got urologists working for me. What do you got? And that's the way it is. That's the truth. It was just that blunt.
Yeah, I think that,
you give
you're
your
honest.
services, they'll take them.
Absolutely. And I think your honesty really resonates a lot with
I
the
hate to say that
frustrations
because,
we've heard.
it's a cynical thing to say, but I have come to that conclusion. Now, let me tell you, and they say, well, oh, but we can't, we're spending, and America spends way too much on medical care. Why? Well, I'm going to tell you, the insurance companies are the ones taking the big bite out of that. Right now, the obvious low-hanging fruit is the pharmacy benefit managers, PBMs, right? Every one of you should take some time. It would be about a 30 or 40-minute study to learn what they do with drug prices, because it's obscene. I can go online and buy about 1,200 different generic drugs for between 5 and 10% of what my insurance company is paying for those, or says they're paying for those drugs.
Yeah.
So if my copay is $10 and I can buy the entire prescription of medicine for $3, by the way, that United and Blue Cross, they can all get the same deal I get. I'm paying retail. And so why is it
tough.
10 times more? And the answer is because of their PBMs that have bundled these payments. They're getting kickbacks, fees. There's about 6 or 7 different schemes in that program. But here's the number to take away. If you take no other number away from this tonight, take this away. PBMs steal out of the middle of the healthcare equation in America between 100 and 200 billion with a B, bravo, dollars a year, every single year, and add zero value to that proposition. And they've done that with a series of moves that could most kindly be called chicanery. And it's just, that's ridiculous. And don't take my word for it. Go online and see what you would pay in generic retail pharmacy. There's a bunch of them. Mark Cuban's is one. GoodRx is another. I find Mark Cuban's on average is lower than most. There's another one I've forgotten the name of. But I mean, it is literally, it runs between 5 and 10% of the cost that my insurance company will recognize and say that they're paying to the pharmacy, but they own the pharmacy too, by the way.
Yeah.
So
it's tough. I know that we've talked about some research being done in the urology space, so I think it's an issue that is just one more complexity, of this system that can be really frustrating for physicians and patients alike. But for us urologists who are here engaged, we're here on this webinar hoping to hear your thoughts on what we can do to improve the physician fee schedule and make sure it's more fair to those struggling independent practices you talked about. How can urologists aid congressional efforts, in your opinion?
So the reason I mentioned PBMs, which obviously probably affects almost nobody on this call personally, is I doubt, I don't know what, who owns a PBM on this call? Probably nobody. But what we look for in Congress is a pay for. Okay, so if we want to give a 10% raise to every physician on the CMS schedule across the country, which actually would be, lag way behind what's happened with inflation for the last 3 years. If we wanted to do that, it would, let's call it 15 billion. It might be 18. It's in that range, $18 billion. And I'm telling you that we're losing 100 to 200 a year to the PBMs who do nothing. That's your pay for. That's why you should know about PBMs. And then you can go to your congressman and please do go to your congressman and light them up on this stuff and say, these people are stealing from you. You're stealing from a big country and you're willingly allowing them to do that. And that's out of ignorance. I mean, I really think there are very few congressmen who actually would endorse this once they understand it, but you got to let them know that you care about it.
Yeah.
And then you got to, some of you are in specialties where you can afford to step out of CMS payment for a while. Urology, I guess we're all urologists here tonight, aren't we? Sorry, guys, that's tough.
Yeah, we are.
Urology, right? I mean, you got the very old and the very young, Medicaid, Medicare. It's tough for us, right? Which is why you see so many people going to work for hospitals. What's the turnover rate for staff at hospitals? 20% a year, roughly. right? People go to work for a hospital, they're dissatisfied, they're not allowed to practice the way they want to, they can't prescribe the drugs they want, they leave. Another few years later, they leave. And that's an enormous cost to the medical system too, and it's actually costing quality if you don't get to know your patients, right? So, I mean, I think the important thing here is to find that pay for, hammer it home to your congressman. And we talk about, by the way, it's literally not a single member of the doctor caucus that doesn't know this and believe it in their heart. D or R are all on the same page with this. But the health insurance companies are the single most powerful lobby on the Hill. They're more powerful than defense. They're more powerful than the defense industrial complex, whatever you think. They're far more powerful than pharmaceutical companies. I used to think they might be the bad guys. They've actually been dragged into this as unwilling accomplices, for the most part, unwilling. It's clearly the siloed insurance company. And the three biggest are Aetna, United, Cigna, and they each have their PBM, and there's about 5 big box wholesalers in the country: CVS, Walgreens, Walmart. I won't speculate on the GPOs, but there's a couple of them. You probably have heard the name of them. And they are all owned in silos. So, they own each other, and then the money just goes back and forth between these subsidiaries. I was on the Blue Cross board when that was created, and I didn't understand the structure that they were creating. And now I do.
Yeah, it's definitely problematic. And, I think it's a great way to leverage another important issue in healthcare to support our initiatives as we advocate for, payment reform. So I do appreciate you really hammering that point home. What other reasons or anecdotes resonate best with you and your colleagues, specifically those congressional representatives who may have a bit of a limited understanding of this issue?
There's a large group of those representatives. Let's start with that. But some of the efforts we did, we thought, okay, let's do value-based pricing, right? MACRA, right? Failed. Why? Because we couldn't get the Stark laws undone. I mean, so we have 2 sets of laws in the book that fight each other. So nothing gets done with MACRA. MIPS, by the way, MACRA was before I was ever elected. I'm on my 4th term. MIPS, the merit-based incentive payment system, it failed too. It didn't really, increase anybody's compensation. It just said, okay, 1 year you get a bonus, but the next year, that's your threshold. You got to beat that again. So it's not enough to save money, to save 10%, the same 10% year after year. You got to save 10% over the 10% you saved the year before.
Yeah.
It's ridiculous. Your budget neutrality is obviously, it sounds like a good thing. It has that sort of warm, fuzzy sound to it. But if you say you're never, ever, ever going to increase the number that you're going to pay for CPT codes, and you have 10% inflation, what happens to the poor guys and gals who are living on that same number every year?
Yeah.
I mean, that's it's untenable. And everybody else, the price is anybody, if there's somebody on the phone call who's paying their staff less now than they did 3 years ago, I'd love to hear from them, and I'd love to hear how they're doing it. I bet there's nobody.
Yeah.
But I bet you're all paying yourselves less.
Yeah. I mean, labor challenges are definitely a major issue right now. Thank you, Dr. Dunn, for that really important discussion. I'd like to take a moment in our last 5 minutes of the webinar to open up questions from the audience. So we have a few.
Everything's fair game, by the way. You be careful what you ask for. I'll give you the truth as I see it.
Yeah, we love it. We don't want any sugarcoating here. So I have our first question coming in from the audience. As you say, Congress isn't sympathetic to financial arguments from docs. The reality on the ground is lawmakers' constituents are suffering increasing morbidity and mortality from physician shortages, particularly in rural areas. Some of this is a GME problem. Some of it is also payment squeeze to providers, which causes smaller independent practices to either close or join more expensive models of care. Does this line of argument resonate?
Oh, absolutely. That's 100% true. And thank you for bringing in the rural areas. I live in a fairly rural area. It's becoming more, less rural, I guess I could say, not actually urban, but yeah, it's absolutely true in a shortage of doctors in those more rural areas, because who can make a living in a small town as a urologist? It's it's just almost impossible anymore. And the hospitals will only pay you so much, because I mean, they're coming in as low as they can too, right? Uh,
Yeah, yeah,
so,
it's tough. And the AUA, with your support, I know has really been working hard towards some legislative solutions to rural access, such as the Spark Act. So, we hope to tackle that important issue as well. Let's see if we have any more questions coming in. Can you share a bit about how impactful constituent voices are in your line of work?
very. So my staff constantly says, this is what we're hearing from the district. This is what they're calling or writing about. And by the way, we look at every email. We listen to every phone call. We return all the ones that don't have any 4-letter words in them. And so it's, I mean, if the answer is, if they have a running flow, it can't be just one constituent keep calling back, right? So and also your associations, use them to lean in there and say, this just isn't going to work anymore. And there's some wonderful statistics too. How
Mhm,
many independent practitioners are left in America total? Maybe 25%, maybe
mhm.
25%. And if you're not working for your patients, who are you working for? The system you're
It's
working for.
true.
And you're limited by that system. Just try to prescribe drugs they don't have. Just try to prescribe, diagnostic tests they don't do. And you know what I'm saying. Yeah. It's very tough to be cutting edge medicine practicing in a system that makes money on billing day by day.
Yeah, absolutely. I
So the
think we have time
quality that
for,
we all want is
yeah,
elusive.
yeah. I think we have time for one last question. Does CMS have any patient access concerns? Is this even in their equation? Urologist attrition rates are high. And how about patient advocacy groups trying to talk to their congressional representatives pushing for more access?
Ironic you should ask this question today, because earlier today I had the director, the CMO, actually, so he's Chief Medical Officer of CMS, Dr. Hughes, in a hearing. And I got a chance to ask her that question. And the short answer is no, they have no concerns, because every time they put out a new payment schedule, it gets accepted by 95+% of physicians. And so I go to them and say, pretty soon you won't have any docs. And they're going, well, right now I got all the docs I can handle. And
Yeah,
so the answer is no. And that's the same answer, remember, I gave you from Fred Levin,
yeah,
over a dozen years ago, which, as long as they can, remember, they equate quality patient care to coverage of any sort, whether it's an
yeah.
HMO, Medicaid, CMS, or I have the worst health insurance I've ever had in my life here in Congress. It's awful. I mean, you can't believe the deductibles, the co-pays, and what I have to pay out of pocket. It's all right. Don't feel bad for me. I saved up a little money when I was practicing, but for the love of God, you've got 50 congressmen up here sleeping in their offices because they can't afford a room in Washington at night.
Wow.
This healthcare insurance is really, well, you know why? We required Congress to take Obamacare when we passed Obamacare. That's the only group that has to take it. We can't. My staff, I can give federal health insurance to. Me? No.
Got it. Got it. Well, thank you for your insider perspective. We really appreciate you taking the time to chat with us tonight. I think you brought up a really important set of points on how we as urologists can better advocate for our profession and in turn for our patients to ensure that the Medicare physician payment fee schedule is actually something that works for all doctors, independent practices, employed physicians, all of us urologists who are trying to provide excellent, high quality care. Thank you again, Dr. Dunn.
Well, I want to say thank you to you, Dr. Talwar, because I'm talking to people who took time out of their career at a time when it was probably more painful than the time I took out of my career. You came up here and you learned some things, and I fully expect that you will be a leader in medicine for decades to come. I'm going to hold you to it.
Thank you. Thank you so much, Dr. Dunn. It's always a pleasure to chat with you. And thank you so much to our attendees for spending time with us this evening. We really encourage all of you to attend the 2024 AUA Summit in Washington, D.C. in February of 2024. Hopefully we'll be able to meet Dr. Dunn and some of his colleagues and, take these really important issues and our perspectives as physicians to the halls of Congress.
We're going to be raffling off a TERP for me.
Oh, you heard it here first, folks. Thank you again, Dr. Dunn. Have a wonderful evening, everyone.
You guys take care. Have a great night. I always enjoy spending time with urology.
Thank you for listening to the Leadership and Business Podcast. We invite you to discover the full range of leadership and business programs offered through the AUA Institute for Leadership and Business. Simply visit auanet.org and navigate to the Leadership and Business tab to learn more.